Good afternoon, everybody. Many thanks to Dr. Srinivas Reddy and the organizing team of Star Hospital for this invitation. It's always a bit worrying when you start to get non-clinical topics for your presentations. So that means that it's time for your Lifetime of Achievement Award and it's time to retire. I certainly hope that's not the case here, Dr. Srinivas. But the good thing is that thanks to the unusualness of this topic, all the slides are very fresh. These are my appointments. I don't have any disclosures, and all the slides have been made the old-fashioned way here. So why is this important? We know that liver transplant is a very technically challenging procedure, and difficult transplants can lead to higher postoperative mortality, morbidity, and hospital stays. But surprisingly, there is no clear definition of difficulty. Firstly, how do we define difficulty? And secondly, can we predict which patients are going to behave poorly? Why is it important? It helps us make better decisions, both when we talk to patients as well as when families are making decisions regarding risk and benefit. It helps us to decide the selection and acceptance of grafts and donors, and most importantly, it helps to decide logistical and resource planning. If we anticipate difficulty, we would probably plan to do it at a time when senior members are available or our entire support system is in place. So I'd like to break this down into 5 points here: recipient factors, donor factors, logistics, system readiness, and surgical skill. What are the recipient factors that may interfere or influence surgical difficulty? Firstly, age. No matter what we say, age is a factor. The older a patient, the less able they are to handle complexities and, more importantly, complications. Frailty is coming out as an important marker, and rightly so. Most of the patients we operate are on a sarcopenic, and certainly a patient where we are expecting multiple comorbidities who also has sarcopenia would be somebody in which you could think about difficulties. Obese patients, we are seeing a lot more of these, and certainly this adds to surgical complexity and difficulty. Surgeries, comorbidity, and MELD score is decided. Other recipient factors: the presence or absence of ascites. Sometimes the presence of ascites is actually a good thing because it increases the abdominal domain, makes your dissection a little bit easier, and helps to do an easier explant. However, if you've had multiple episodes of SBP, that can increase the number of adhesions that you see inside the abdomen and make for a complex explant. If you had a TIPS, in fact, TIPS patients are actually more difficult to do explants in because typically the collaterals close up and they tolerate portal vein clamping much more poorly. So certainly the presence of TIPS is actually a relative problem. And the status of the patient, if you have ALF, ACLF. The indication for transplantation. Now, if you have a patient who has cirrhosis and portal hypertension versus a patient who does not have portal hypertension, then the implications are quite different because both these patients handle portal clamping very, very differently. If you have a patient who has an anatomically normal liver, which you then do a portal clamping for, these patients will tolerate that very, very poorly. What other factors are you looking at? When you look at the imaging, if you have a very large liver, for example, in a pediatric situation, in a cholestatic liver disease such as biliary atresia, or a PSC liver, you can anticipate a difficult explant. If you have portal thrombosis or cavernoma, this will come up again and again. These are factors that will make for a difficult explant and an implant. If there has been previous intervention, or if you anticipate the need for cable replacement because of a large chordate lobe. One new factor, of course, is that we are seeing a lot of patients who come to us through the transplant oncology route. Dr. Madhu talked about it very briefly. So there are patients who have had neoadjuvant chemotherapy and radiotherapy who will come to you with fibrosis around the porta, for example, which can lead to a difficult explant. So the first score that I'd like to talk about is a score that encompasses these. This paper actually came out of France. This looked at a difficulty score, giving a score of 0 to 10. And essentially it picked out 5 factors: retransplantation, that is late retransplantation, ascites, a portal vein thrombus, an annular chordate that encompasses the entire IVC, or the presence of TIPS. And as you can see, there's actually quite a nice correlation between the morbidity that you see on the left and the mortality, the risk of mortality as the difficulty score rises. But as you can see, even from when the difficulty score is 0, there is a very wide spread of morbidity and mortality. So clearly, while complexity is one factor that affects mortality, it is not the only factor. Looking at donor factors, Of course, it matters significantly if you're talking about a DDLT or an LDLT. The graft size is important. Large grafts are difficult to handle in a DDLT setting, especially if the abdominal domain is small. But also, paradoxically, a very small graft can be a problem. Because after doing a cable if you're not doing a cable replacement, for example, the graft can fall back and cause a kinking of the outflow. Has there been any previous surgery? Is there any aberrant anatomy? Or has there been any damage during retrieval? When we talk about damage during retrieval, this is actually quite a common problem, especially in systems where retrievals are done by teams that are different from your own. This study came from Netherlands. Actually, it reported a 6.6% damage of organs which were retrieved by other teams. And when damage included arterial injury, it caused a heart injury rate of almost 23%. This study was further carried on by the entire nationalized Netherlands system. And over a 10-year period, they identified a high BMI, aberrant anatomy, a DCD donor, and male gender as factors that were associated with damage of the organ during retrieval of the organ. And in fact, this was a significant problem because 4% of the organs that were retrieved with damage could not be transplanted. So there was almost a 4 to 5% loss of grafts because of a damaged organ. I shan't talk too much about the DRI or the European equivalent because these are more generic things. They don't specifically talk about surgical difficulty, which is actually the point of the topic. So what about living donors? Of course, it depends whether you're planning a right lobe or a left lobe, whether it's open robotic, whether there's aberrant anatomy, arterial veins or bile ducts, if there's a complex reconstruction planned, or if there are additional procedures planned such as flow modulation. So a paper from Dr. Srinivas Reddy himself looked at the difficulty score of a right donor hepatectomy, and essentially they defined difficulty as a longer operating time or transaction time, blood loss as well as vasopressis. And they of course found that difficult hepatectomies had significantly more perioperative morbidity. But more importantly, they found that the size of the right lobe, a diameter of greater than 14 centimeters, was the best predictor of a difficult donor hepatectomy. And this is a theme that we see even in the laparoscopic era. This is a paper from Japan that looked at left lateral segmentectomy. So the surface area that people had to transact between the right and the left lobe, obviously the more the surface area, the more difficult the hepatectomy was. So by logistics, again, this is something that I'd really like to get some inputs from the crowd about. There are obviously two aspects to this. When we have a DDLT, where are we doing a retrieval? Are we doing a retrieval in our own hospital? Are we doing a retrieval in a peripheral hospital? Clearly, the systems that are in place that will help you alleviate surgical difficulty are more well developed when it comes to your own hospital versus if you're traveling outside to do a transplant. These things impact the cold ischemia time, which can increase the reperfusion injury. How well are you coordinated between your donor and recipient teams so that you can actually time your transplants better? Now, regarding implant, again, this is something that I know that many teams transplant in multiple centers. Is there a system of triaging that needs to be put in place? For example, if you have a simple implant, a relatively straightforward implant, it can be done in a peripheral center. And if there's a complex implant, whether it should actually be referred to the primary center. This is something that probably teams that operate in multiple hospitals should think about. What is the level of difficulty that they would accept in a home center versus a satellite center? Now, system readiness. This is an interesting paper that I'd like to talk about. This is a paper from Taiwan, covered 14 years of almost 3,000 recipients. Now, it's always the question, isn't it? Is it the dance floor, is it the dancer? Is it actually the surgeon, or is it the system that actually is important? So they actually looked at this in great detail. They looked at high volume surgeons who had done more than 100 transplants versus high volume transplant centers which had done more than 300 transplants. So they followed the system where they narrowed it down to the distinguished patients who were operated between high case volume surgeons and patients who were operated in high case volume hospitals. And surprisingly, or perhaps not surprisingly, both were important. When you look at the high case volume surgeons, they had a much better survival as compared to low case volume surgeons. And the same thing with hospitals. The high case volume hospitals actually had a much better survival as compared to low case volume. So definitely case volume is a surrogate marker for perhaps preparedness to transplant to report complications. There have been a few composite scores that have been proposed in order to assess the level of difficulty of a transplant. We already talked about one from Kitano, that they all have come from France actually. This is another one, this came from Barcelona as it happens, where they've identified 4 factors: retransplant, preoperative PVT, pre-operative surgery, and SBP, 5, and prior variceal bleeding as risk factors for a difficult transplant where you could anticipate difficulty, for example, for DDLT. Another paper from Dr. Azule, where they actually defined difficulty as the number of blood transfusion units used, cold ischemia time, and the duration of operation, where they also identified previous abdominal surgery, ICU admission, and use of split grafts, non-standard arterial reconstruction as predictors. The most comprehensive score came from Hospital Saint-Pietre, which was actually a group from France, 987 centers from 5 centers. They actually came out with a very, very elaborate score, which looked at all the different domains we talked about, pre-operative, perioperative, and donor and recipient factors, and came out with a score. But just to show the difficulty of these composite scores, the highest mortality was reported in the moderate difficulty level, not in the high difficulty level. So obviously there is no linear relationship, much as I would like it to do. I'm going to spend the last 2 minutes talking about surgical skill. That's a very, very nebulous thing. How do you define surgical skill, and how is it actually quantifiable and measurable? How does it actually contribute to surgical outcome? It's very surprising that there are so many papers across, not just transplant, which actually don't account for surgical skill. Like we have all these papers looking at outcomes after colorectal cancer. Nobody talks about surgical skill as a predictor outcome when we know it's such an important outcome. And the first study that I can think about, which actually looked at the European data, was the Bonnekamp study on D2 gastrectomy, where they actually standardized for surgical experience before they actually did the randomization. So surgical skill, how do you define it? It's like the definition for obscenity, right? I know it when I see it, but it's very, very hard to actually define what surgical skill is. So the definition of surgical skill actually is a very surrogate thing. The operative speed, the number of blood transfusions used, the length of stay, the morbidity, mortality. As the Bible says, right, you should know them by their deeds. Actually, you know them by their outcomes rather than actually as a direct measure. And unfortunately, there is no direct measure of how what surgical skill says here. But what we do know is that surgical skills can be taught. We know that people who are put through a structured training program will improve their outcomes, whether it comes to organ retrieval or when we train transplant surgeons in a virtual setting. And this is something that we have tried to do in the course that we run. We have run the course now for the last 11 years in Bangalore, which actually focuses on organ retrieval. Over the last 2 years, we have developed our own homegrown trainer, which you can see is a plexiglass monitor. These are silicone models of the liver as well as arterial and venous anastomosis. And the plexiglass system is basically to simulate difficulty in suturing, so that you can see here, this trainee is actually bending over to actually do a cavostomy. Somebody is retracting the liver for them, and they are actually replicating their movements. So they are trying to do a side-to-side cavostomy. The red tube and the blue tube are actually the donor and the recipient cavas, not the aorta and the IVC here. So we looked at the results, the satisfaction results of these 25 patients, of these 25 people who went through training through the simulator. Most of them felt that the anastomosis replicated real life. The vessels were easy to suture. And although a lot of people disagreed on whether it was close to normal tissue or not, everyone agreed that this should be included in future courses. To summarize, surgical difficulty can be anticipated. Anticipating difficulty is preferable, because if you anticipate difficult cases, you need to have your best team on the job, make sure that you're operating at a time when your resources are available in a center that can support complexity. Most measurement tools are surrogate. Measuring skill is difficult, but what we know is that surgical skill can be taught. Thank you so much for your time.
Thanks, Sonal. As usual, a very comprehensive talk. I think I tend to divide difficult transplants into the ones that are difficult at the time of doing the operation, like previous additions, and the ones that are difficult for the entire future life of the patient and the graft, like for example, a portal vein thrombosis. And I think the key is as you grow, the technical difficulties become less. But I remember losing a patient because I could not get portal flow because I had not prepared well enough. So complete portal vein thrombosis, have a backup plan as a, for example, a renal portal, have a backup plan to that as a cable transposition. Otherwise, you'll end up in a situation where you have a warm graft, no inflow, and things like that. So I think what you said is the key, preparation. Great talk. Any questions?
If you look at pancreatic surgery, so initially Vipul's giving very high mortality. Then there are landmark trials came, high volume center, give a less mortality. Look at the same way, this is also one of the complex surgery. When you see that recipient factors and donor factors indicating it is a high risk case, that type of surgery should be done a better high volume center or better experienced surgeon that it will give a good results. So
Sure.
look at always as a overall recipient factors, donor factors, and surgeon or hospital volume. It decides. If your center is not at all a high volume, at least senior surgeon should do that type of high risk cases.
Sure. Now, I think one of the things that the reason why I think this talk was given is because we are planning a study called the Living Donor Risk Index using the Indian Liver Transplant Registry, where for the first time we are trying to look at adding the element of skill and surgical complexity as a variable. Like, for example, the data that we capture is number of arteries, number of veins, number of reconstructions, high volume versus low volume center. So we are trying to incorporate that into an AI model that will tell us what is the risk for an individual patient. And certainly as the LTSI, I would like to see perhaps a preceptorship model set up where if we can identify such patients in advance, people can call out to centers that are more experienced to perhaps ask senior surgeons to come in and help. And that would probably be a much more enabling model ecosystem for all of us.
Thank you.
Thank you.